In this video, we'll go through the ABCDE approach for the acutely ill patient and also talk about adult cardiac resuscitation. So start with washing your hands, wearing any protective equipment such as gloves, gown, goggles. Inspect and look for any danger. Make sure it's safe before you approach. Introduce yourself to the patient, family, carers. Identify the patient. Talk briefly about the procedure. Take consent. Talk about chaperones. Talk about confidentiality. At this stage, if you wish, you can also ask about any cervical spine injury. Expose the patient appropriately and make sure patient is appropriately positioned. First, speak to the patient. If he speaks back to you, then he is at least alert or responsive to voice on the ABPU scale. Alert, response to voice, response to pain, unresponsive. It's likely then that the airway is well maintained, in which case you can simply ask him to open his mouth and you can look inside to make sure there is no foreign body or loose dentures. If the patient does not respond, then you look, listen and feel for 10 seconds. You're looking for chest expansion. You're feeling for a carotid pulse and also feeling on your cheek for any breath. And you're listening for any breath sounds, any gurgling or any apneic episodes. Of course, if there is no spontaneous breathing activity or very less and no pulse, then you move to the cardiac resuscitation cycle. Otherwise, you stay within your ABCDEs. If you're happy with the airway, then you can move on to breathing. If you're not so happy, provided the patient has not had recent cervical spine injury, you can do a head tilt and chin lift maneuver, consider a Goodell's airway, ask for help in order to get a definitive airway. Moving on to breathing. You will have a nurse to assist you. Nurse, may you please measure this patient's oxygen saturations and his respiratory rate. Thank you. Inspecting the patient generally for any cyanosis, effort of breathing. Inspecting the trachea to see if it appears midline. Inspecting chest expansions to see if they appear to be symmetrical on both sides. Palpating the trachea to ensure it's midline. Palpating the paropharyngeal spaces for any crepitus. Palpate ribs and chest wall for any significant tenderness, chest flailing, paradoxical chest movements. Percuss both sides of the chest, looking for any hyperresonance or dullness. Auscultate both sides of the chest, looking for normal vesicular breath sounds on both sides. You would then pull the patient forward, repeat inspection, palpation, percussion and auscultation on the back as well. By now, saturations and respiratory rate should be back. As this is an acutely unwell patient, put him on high flow oxygen 15 liters via mask, non-visible bag. Keep a close eye on the sats. Moving on to circulation. Nurse, may you please measure his blood pressure and pulse rate, please. Thank you. Inspecting the patient for any obvious cyanosis. Inspecting the periphery for any mottling. Inspecting the hands for any signs of bacterial endocarditis such as splinter hemorrhages or rot spots. Palpating the pulse, looking for a thready pulse or a bounding pulse. Checking capillary refill time, both centrally and peripherally. And finally, auscultating the heart sounds. By now the blood pressure and pulse rate should be back. Gain IV access with 2 wide bore cannulae in each antecubital fossa. Take blood tests for blood count, kidney function, liver function, amylase, clotting, blood culture. Group and save. Start the patient on IV fluids, 1 liter of warm Hartmann solution, stat. Nurse, may you also insert a urinary catheter so we can measure fluid output. Moving on with disability. First, check the alertness scale. See if the patient is alert, responsive to voice, responsive to pain, or unresponsive. Check the pupils for reaction. Check if they are pinpoint or dilated. Ask the patient, if alert and responsive, to carry out a motor function. Wiggle his fingers, wiggle his toes. At this time I would also do a Babinski test to look for an extensive plantar response, which might suggest an upper motor neuron lesion. Moving on to exposure. Nurse, may you please check the patient's temperature and do a urine dipstick. Expose the patient appropriately. Look at the skin for any rashes, bruises, injuries, bleeding. Look for blood on the floor. At this time I would also examine the abdomen, palpate the loins, palpate the groins, and if appropriate, examine the genitalia and rectum as well. If the patient is hypothermic, cover him with a blanket. If the urinalysis test is abnormal, considering treating that. Now, if the patient does not have spontaneous breathing and circulation, you need to start resuscitation. Start first with a ratio of 30 compressions to 2 breaths. Once you have a definitive airway, you can bag the patient at 8 to 12 per minute and do continuous chest compressions. Try to put defibrillator pads as soon as you can and check the rhythm. Shockable rhythms are VF and pulseless VT. Non-shockable rhythms are PEA, pulseless electrical activity, and asystole. You will shock every 2 minutes if the patient is within a shockable rhythm. Keep the patient on high flow oxygen, aiming for SATs of between 94 to 98%. Push through fluids, having taken blood tests for venous gases. You would consider the 4 H's and 4 T's, which are treatable causes of cardiac arrest. The 4 H's are hypoxia, hypothermia, hypokalemia, hyperkalemia. The 4 T's are tamponade, cardiac tamponade, thrombosis, either pulmonary or cardiac, toxins, or tension pneumothorax. 3 minutes into cardiac resuscitation, you would consider adrenaline, and if the patient requires more than 3 shocks, you would also consider a amiodarone. Once the patient appears to have spontaneous circulation in the form of a pulse, you move back to the ABCDEs.